Thank you, Sudha ma'am, for the opportunity. In the 15 minutes, we are going to discuss first how to do a ideal vitrectomy, and in the secondary IOLs, why these principles or ideal vitrectomy rules are getting violated. And next, we'll come back. Is there any way we can do a good vitrectomy before a secondary IOL also? So for this, before going to the vitrectomy, basic anatomy is, as we know, vitreous has a 6 attachments. Strong attachments are there at vitreous base and at the margins of the disc. So our aim is to clear the prolapsed vitreous from anterior chamber, not from the vitreous cavity, without causing the traction. So for that, rule number 1, either it can be rule or a principle, never allow your anterior chamber to collapse. So here you can see here, there is a punch out I noticed while doing the phaco. So I didn't take out the probe immediately. First I inflated the visco. So here I noticed a punch out during the phaco at this area. So immediately when I noticed it, I didn't take out my probe from the section, main port. First I inflated the anterior chamber. Then I took out my phaco probe. Why? Because when you take out the probe suddenly, there is a pressure gradient. High pressure vitreous will flow into the atmospheric low pressure. There is a more vitreous will come, more traction also will develop. Rule number 2 is never go through a main tunnel. Here you can see we have to do exactly side ports which fits the irrigation and vitrectomy cutter, and better to do a bimanual technique. If you go from the main port, the length of the main port is much more than the vitrectomy cutter. So it becomes an open chamber technique. And also in coaxial vitrectomy, there is a continuous irrigation which is flowing into the vitreous, which causes vitreous hydration and causes more and more vitreous to get prolapse. Rule number 3 is irrigation, positioning the irrigation and cutter positioning. Place your irrigation outwards and upwards so that the fluidic influence will be less on the vitreous, and the cutter should be below the level of PCR with bevel up. So in a diagrammatic way, if I show, irrigation should be outwards and upwards, cutter should be below the level of PCR with bevel up. So this is ideal so that it clears the vitreous from anterior chamber. If you place it downwards, it clears the vitreous from vitreous cavity. You can place it sideways also. Rule number 4 is keep maximum cut rate and low irrigation and AFR, because irrigation and vacuum AFR will cause traction. Cutter will cut the vitreous. So here you can see there is a 2000 cut rate. I raised it to highest possible, and IOP is 50. I lowered it to minimum possible 20, and AFR was already low. So with these settings, vitreous can be cleared with fast and without traction. And rule number 5 is always move the cutter in foot pedal 2. You can see here I'm cutting the vitreous. When you want to move from point A to point B, it should be in a cutting mode. If you move without cutting, the vacuum and irrigation, the mechanical movement of the probe also causes traction in the vitreous. And rule number 6 is don't wake the vitreous. This is a predominant practice in many of the centers till now also. So if you use a weck to cut the vitreous which is prolapsed outside the tunnel, it causes a break. And rule number 7 is never loop out the vitreous. If you do fishing, the same result. It causes break and traction. Next is rule number 8. Never phaco the vitreous, because phaco, as we know, vacuum and AFR and the phaco energy itself causes lot of traction. Next is rule number 9. Never jet irrigate the vitreous. If you jet irrigate, that irrigation will go into the micro breaks in the retina, causes retinal detachment. And rule number 11, most important, know your machine. Vitrectomy cutter is a tube in a tube. Outer tube is closed on this area. It has an opening port. Inner tube is that having sharp edge, which moves to and fro, cuts the vitreous which is coming near the opening port. So it's actually two hollow metal tubes which are mounted coaxially. So first, before entering the anterior chamber, check the cutter function prior. So here, how to check a vacuum? Put in BSS and press the foot pedal. That movement of the air bubble shows vacuum is functioning. Here, I went without checking. The air bubbles went into, you can see the air bubbles coming into vitreous cavity. So prior check vacuum first, then check the cutting function. Suppose if you see here, first check the patency. It is open here. Then check whether the inner tube is functioning or not. How to check? If you check at a higher cut rate at 4000, it is moving, but it may not be visible for a naked eye. So we reduce the cut rate to 100 or 200. Then you can see here, if it lower cut rate, we can see with our naked eye, the cutter is moving. Then you enter the anterior chamber. This is a case where it was the patency was open when I checked, but when I entered into the anterior chamber, you can see here, it is open here. When I entered, when I pressed the foot pedal, the tip of the cutter this port was blocked. It's blocked. So I immediately taken out and change the cutter. If I don't know the mechanics of the cutter, I will be moving with the sound inside the vitreous, causing a lot of traction. So with this basic principles, before secondary IOL, in cataract extraction before or IOL explantation, before a secondary IOL placement, what happens? When we are extracting with Vectis, there is a sudden gush of vitreous because of the sudden decompression of the anterior chamber. So vitreous tends to get clogged in the section. So as I told, if I do bimanual vitrectomy here, because of the irrigation pressure, vitreous keeps prolapsing more and more. And if I do another problem with if I want to cut the vitreous which is in the section, there's another problem with the vitrectomy cutter can touch this iris. In this case, you can see the vitreous cutter was touching the iris and caused iatrogenic trauma. So these are the two problems. Vitreous coming into the section. If you tend to cut with the vitrectomy cutter, it may cut the iris. So we have to swipe the vitreous from the section to inside the anterior chamber. Then only we can do a bimanual vitrectomy. So with this spatula movement, you can see a lot of traction is happening as I'm swiping, because there is no other way to cut the vitreous which is in the section. So you can see the traction elements here. So I have to cut with Vanas also. And now after cutting with Vanas, we tend to go through main port with the two irrigation and cutter from the main port. We tend to go because we have to cut the vitreous which is at the section. So now again, I'm only told bimanual vitrectomy is better, but now I am using the main port. So next problem is this tends to cut a lot of vitreous more than needed if you go through the main port. So what happens? This more so this is a post-vitrectomized eye, as I am pressing the sclera here while entering with iris claw, so what happens? The negative suction pressure which is created inside the anterior chamber sucks the contents which are outside the tunnel, like air or blood, which obscures your visibility. So you can see blood is seeping into the tunnel and air also is seeping into the tunnel because of the negative suction created. So what is the solution? There are problems. We should prevent the vitreous to come into the tunnel, and we should prevent the traction without using the spatula swiping inside, and we should prevent this negative suction pressure. How can we do this? These same problems will happen even in IOL explantation also. You can see here, this is a decentered IOL planned for a secondary IOL exchange. If I take out with a McPherson forceps, see, you can literally see the traction elements which are happening while explanting the IOL. So now what can be the ideal dealing way? This is another case of subluxated cataract. Here, I didn't directly take out the subluxated lens from inside to outside the tunnel with a Vectis. What I did is first dial the subluxated cataract into anterior chamber. So after dialing into anterior chamber, first step is to debulk the vitreous with bimanual vitrectomy. So now the vitreous which is supposed to come to the tunnel is debulked with our bimanual vitrectomy. After debulking it, now if you take it out with Vectis under visco cover, now the vitreous won't come. Now you can do bimanual vitrectomy as like we told in a principles, ideal way. You clear sufficiently. Then how to prevent the ink dropper effect? So this can be done by a AC maintainer. In secondary IOL, whether it is iris claw or SF IOL, AC maintainer helps a lot. It prevents injecting lot of visco into anterior chamber and vitreous cavity, which causes irreversible glaucoma. And if you do post-planar vitrectomy also, that visco cannot be washed. So AC maintainer, I suggest to use during the secondary IOL. This can be followed in IOL explantation also. Suppose this is a case of decentered IOL. As I told, first dial into anterior chamber. Then below the IOL, debulk the vitreous. Then you explant the IOL so that vitreous won't get prolapse into the tunnel, so that you can follow all the rules. Other way is saving the bag with the bag fixation. We think that all subluxated cataracts should be extracted. This is a homocystinuria case. If you keep trying some kind of rhexis manovias before extracting, someday you will get it. And if you can get a rhexis somehow, then the things are, then we can fixate this rhexis with the iris hooks, capsular hooks, then extract the cataract. Then put the optic of the IOL inside the bag, fixate with the bag to the sclera. So with the bag fixation, here vitreous won't come at all. This is a more ideal thing, but needs some kind of experience. Thank you.